late. I'd request Richard Assaker to please share his screen. He's going to be talking about sagittal balance and adult degenerative deformity. Richard.
Thank you, Salman. I thanks God I didn't have the classification. Thank you, Honor.
Good.
Good. So my talk is about how to plan surgery for according to the sagittal balance in adult degenerative deformity. And I first would like to acknowledge and thanks my friend Daniel Chopin that he taught me all what I'm going to talk about. And because of him, we are still running in the neurosurgical department this kind of pathology, which was completely fiction a few years ago. So what are the goal? And if you look back to Jean-Charles Louek, we've been talking about the global balance, which is an issue, of course, but not only global balance. We have to make sure that the regional alignment, the harmony of the spine, and mainly lumbosacral junction and lumbar spine is mandatory. So the only parameter that is getting back to whatever value of global balance is not sufficient. We have to get some kind of harmony. And also, of course, we should not neglect the compensatory mechanism that gives us an indicators about our corrections. So I will not go for all the theory about what is global balance. It has been said. And again, this paper is well known about the spinopelvic harmony and all the global parameters. And the same paper talks about the measures to correct about SVA, pelvic tilt, and lumbar lordosis. And we all know what is the PI-LL mismatch. But this is not sufficient, and it's not all about correction. So it's a myth about PI-LL mismatch, and Jean-Charles Louek showed us some same values with different spines. So what I have been taught and what we've been working on since years is the local correction also in the lumbar area and the lumbosacral junction. And we know today that the lumbar region had two arch, the upper and the lower arch. The upper arch is constant, and the lower arch is correlated to the pelvic incidence. So what actually is very important and elegant is to match the lower arch of the lumbar area with the pelvic incidence, and higher is your pelvic incidence, bigger is your lower arch, which could be L4-S1 or sometimes L3-S1. So, and again, if you bring your lumbar lordosis by just hyperlordosing your upper lumbar spine, you might have a nice global balance, but not a good harmony, and we might have discomfort in the future. So it's very important to think also the lower part of your lumbar spine from L4-S1, and in sagittal plan, Jean-Charles said it, 70% of the lumbar lordosis has to be between L4 and S1, and we know how frequent is hypolordosis at that segment. And coronally also is very important, and I will show you some examples. The superior plateau of L4 has to be leveled parallel to the superior end plates of S1 in order to start your correction. So leveling L4 parallel to S1 is the first thing you have to do and to think about correction. There is many ways of getting this correction, either by asymmetrical T-lifts, placing asymmetrically cages, or even more radical, having asymmetrical PSO. It depends if your disc is mobile or if you have a rigid segment that needs osteotomies. This is an example here of a patient who had an adult degenerative deformity. And if you look to her x-rays, this is old x-rays from Danielle, you can see that L4 is completely oblique toward S1, and also sagittally she had a positive balance with a complete shift of the trunk anteriorly. So by planning your correction, first of all, you have to think about L4S1, not only sagittally, but also coronally. And this is how it works. You can see here, I don't know if you see my mouse, you can see the parallelism of L4 to S1 and this domino on the convex side that is used to compress the convex side and to get a coronal correction. In the sagittal way, we have placed also a hyperlordotic cage to get the sagittal alignment. So again, you can see that the lumbosacral and the distribution of the lordosis is optimal. And this is the post-op photo of the patient. Let me give you a counterexample. This patient had almost the same deformity, and the correction of this patient was suboptimal. You can see that after the surgery, the coronal axis still not balanced, while the sagittal plan is okay. And you can see that 18 months later, you have a hardware failure because probably of this issue. And again, we use the domino techniques in order to balance and asymmetrical PSO of L4 to get a coronal realignment. So when it comes to planning a correction, I think it's mandatory to have a virtual planning first and simulating your correction. This is very important. It's all about strategy, not about tools. So, okay, first of all, global balance is an issue, but restore lordosis and the good distribution of your lordosis. Make high attention on the lumbosacral junction. Look on your CT, look on your EOS to see if it's mobile or rigid, and what are your capabilities of realigning the lumbosacral junction. And according to this, we will choose a type of osteotomy or the type of instrumentation, whether you go for 4 rods construct or all type of technical issues. So we have tools to get the preoperative analysis, and this is one of the tools that allows us to measure the parameters on the left before surgery and on the right after the surgery. And I will go through some illustrative case. This is another case here that has been preoperatively planned. We know that this is a Parkinson, so no way to stop at the thoracolumbar area. We went till T2 with a good lumbosacral and ilium fixation, and this is at the level of the osteotomy of L3. We've done a 2-rod construct here. So let me give you a quick example of a very illustrative case here. This is a lady, she's 63 years old. She has axial pain and anterior shift of her trunk. She had claudication, neurogenic claudication, and the walking distance is 100 meter. All the prompts are bad. She's really disabled by this deformity. This is our patient here. She stand up with some anterior trunk flexion, and walking is miserable. She cannot walk more than 100 meters. She is very tired by trying to compensate permanently. This is her EOS measures. This is completely degenerative conditions here, coronally and sagittally imbalanced. In order to see where to stop, we just clinically measure how able is a patient to compensate by a muscle component. You can see here, so she's unable to extend her thoracic spine. So we plan to go from T2 till the sacrum. This is traction maneuvers to see how flexible is the apex here. And then very important is to measure, is to look at the synostosis. And you can see that the upper lumbar area is completely fused here. And sagittally also, we can just assess all the disc. And when you see vacuum phenomenon here, you know that you are able to mobilize the segment easier than when it's completely there's no gas in it. This is also the axial. It's very important to look on the CT scan, to look on the EOS, and to look also, and this is our 3D reconstruction. Again, you can see that this is a rigid segment here at the upper part of the lumbar area. We also, because she has also a claudication, so MRI is mandatory. And if for some reason you have to stop in L5, for example, L5S1 disc has to be assessed by an MRI. So here, how our way of evaluating preoperatively. This is the software we're using, the viewer with the spinopelvic parameters given automatically. You can see that the pelvic incidence is 58.2, pelvic tilt is 35, which is indicates the strong retroversion. Sacral slope is 23. And this is how we do. We bring back the pelvis till normal. We bring back the retroversion till normal here. And as you can see, because it's a compensatory mechanism, the patients fall down. So we start getting virtually the corrective measures by doing Smith-Peterson osteotomies here on all the levels. And we assume that a Smith-Peterson osteotomy will give you in between 6 to 10 degrees of correction. So we simulate, it's just a simulation, Smith-Peterson osteotomy at all the lumbar levels here till the thoracolumbar area. And we still not well balanced. So we went back for more aggressive osteotomy in L3. Remember, L3 was fused also, it's a rigid segment. So we've done pedicle osteotomy at L3 with the assumption that we can get till 30 degrees of correction. With all of that, we are balanced. So preoperatively, we know that we have to do a Smith-Peterson osteotomy at all the levels till the thoracolumbar area, and pedicle osteotomy at L3. And this is what we've done. And you can see here the post-op correction in the sagittal way here with, of course, we filled the anterior colon because of the weakening at the osteotomy site. We grafted by a TLF technique. We use the dominoes also in order to compress and get a good coronal balance. So this is the post-op x-rays here, and you can see that the retroversion is completely reduced. And this is a patient preoperatively, and you can see the patient a year after surgery having a better and a more fluent walking, and she gets back to a better quality of life. This is, I would say, our routine work, but in some situation and more recently, we also relies in certain circumstances on anterior realignment associated to posterior percutaneous fixation. I do believe that if you you realign anteriorly, doing an open posterior realignment would be more morbid than doing everything posteriorly. But if you are able to realign sufficiently by anterior axis, anterior to psoas axis, and go back percutaneously, could be a good options. So going anteriorly, we can address today almost all the lumbar areas from 5-1 to 1-2. And in this case here, we went from 5-1 to 2-3 by anterior axis. And you can see the anterior cages here and percutaneous screws in the second stage here. You can see the skin incisions on the flank, on the lateral part here, and posteriorly for percutaneous. An illustrative case here I've done with Daniel Chopin 5 years ago or 6 years ago. This is an 83 years old lady, very I would say general conditions was not really optimal to go for aggressive surgery. She's miserable, ODI 56, back pain, neurogenic claudication, and mainly cruralgia. And this is the MRI and the CT scan. And again, you can see the vacuum phenomenon at all the levels. So we assume that by anterior axis, we would be able to realign these patients. And this is what we've done here. All is done percutaneously. This is anterior to psoas axis. One level here, L4-5, L3-4, L2-3, and you place your cages and then flip the patients and place your screws percutaneously. And you know how it goes percutaneous today. It's a routine work, and this is the post-op measures. Of course, if you look carefully, she's 83 years old. She gets some kind of junctional kyphosis here, but we wanted to do something quick, very minimal invasive. This patient bled something like less than 150 cc's in all the surgeries, and the patient was standing out of her bed in 48 hours after the surgery. So this is before and this is after the surgery. And we had a follow-up of almost 6 to 7 years. Patient still happy. She's not completely pain-free because she had some, we could probably include S1 or go higher on the thoracolumbar area. And this is the scars. This patient had previously in a younger age a laminectomy, of course. So as a conclusion, again, don't think only global balance. We should have some kind of physiological and regional alignment, and mainly at L4-S1. I think this is mandatory. And even if you're operating on a non-deformity pathology, if you are doing a spondy or just a discogenic back pain at L4-5, please have a look on your alignment and what is the lordosis that the patients needs, and do not go for hypolordotic instrumentation. Pre-op evaluation and is very important. Look to your CT, look to all your compensatory mechanism to understand what is going on and what is the alignment of your patients. And then now we have tools to plan and simulate surgery that gives you an idea what kind of osteotomies you have to do and what is your goals. Thank you.
Very nice talk, actually. Are there any questions from the participants?
All the comments we're having is excellent presentation.
I want to ask something to Assaker, Richard, if it's possible.
Yes, owner, go on. One question.
Richard,
yes?
Is there any trick that you can give us during the surgery? Are you making any measurement during the surgery that you have the proper lumbar lordosis that you have
Yes.
during the surgery? I mean, yeah. Are you getting new scoliosis graft? Or what's your key points?
Sagittally is very easy, especially if you have intraoperative flat panels, fluoroscope or 3D fluoroscope, because sagittally you can just measure your angles according to your osteotomy. I believe that lots of surgeons plan to do, let's say, a pedicle osteotomy, shortening of the posterior colon. There is some underestimation of their osteotomies. It's very important because, you know, it's not easy in the osteoporotic spine to close the gap that you create by your osteotomy, and very frequently you under correct the level of your osteotomies. But to check it intraoperatively, you can do your X-ray and measure the angle you get. You have also some kind of tools that you can measure intraoperatively, like some angles. You can measure your angle. But what is more difficult to do is the coronal correction. The coronal correction is very difficult. We solve this problem by doing, with our 3D fluoroscope, we do multiple AP digital shots, and then in a computer stitching software, we can realign, we can place the patient in the coronal, and then we can play with the domino techniques in order to correct the coronal. So some surgeons are able to do a long format cassette to get all the coronal spine intraoperatively. So first, have a good technique. I mean, have your capabilities of doing your Smith-Peterson, doing your good anchor, of course, to the spine, and then you can measure sagittally by your standard fluoroscope, and coronally, it's more sophisticated, but it's feasible. It's doable.
Thank you.
I want to stress your examination technique for thoracic spine. You ask the patient to get deflex in the prone position. Can you tell it again, because it's quite important, I think.
Yeah, patient is lying prone, and we ask him to lift up his shoulders. And you, if they are completely unable to, they use their hands to, you know, to lift up the shoulders. Of course, X-rays gives you big information. If you have a hypokyphosis, you know that he's compensating. If you have a hyperkyphosis, you know that he has no compensation. But clinically, if you are doubtful about how, and if he's relatively young, let's say patient who's 60s, and you don't want to go till T2, if he had a good compensation clinically on lying down prone, you might expect that you stopping at T10 would be enough. I always tell my patients also that even if I stop at T10 and we might go back to T2 in the future if there is some kind of junctional problems or suboptimal correction.
Okay.
Okay, brilliant. I think we're going to move on in the interest of time. Thanks, Richard. Brilliant talk, and really enjoyed that.
Thanks all.